as you know, there are significant workforce shortages at healthcare facilities. We talked about that at length here today, but particularly those in post-acute and behavioral health that are making it difficult for acute care hospitals to discharge patients to appropriate settings. And as you know, this means that patients are remaining in inpatient beds longer than is medically necessary. That certainly comes with a cost. Several patients have resided in our local hospitals for more than a year, and others have seen more than 1,200 referral attempts rejected. And we had talked a little bit about hospice care at a hospice facility and the challenges that we need to work through regulatorily, if that's even a word, to try and get those patients into that appropriate setting. I understand that DHS provides a higher MA reimbursement for facilities that take patients with neurological and neuromuscular diagnoses and several functional limitations. So I'm wondering, would there be a way to expand that effort to meet the needs of a growing number of difficult-to-place patients?
Be happy to look into that. I don't have an answer here today, but we'd be happy to look into that. I think to your point, it's certainly been my experience that patients that run into that problem are usually very medically complex and sometimes have additional complexities that require a certain level of training of individuals at the facility that they're going to. So we can be happy to look into those specifics of kind of what you're thinking and see if there's a path there.
I think it would be a great opportunity, one, to reduce costs, right? That inpatient acute hospital bed is more expensive than some of those other placements. And I think most people are happier to be in a facility that's better able to meet their needs and that level of care. So improving the patient experience and reducing costs, that's a good place for all of us to be. Wanted to talk to you a little bit about prescription drug pricing under MA managed care programs. So there was a study by the Legislative Budget and Finance Committee that identified wide discrepancies in reimbursement for ingredient costs and emphasized the need to have transparent payment methodology, especially in the medical assistance care pricing arena. It also emphasized the need for full disclosure of contractual information between pharmacies and PBMs. And the report showed a difference of 36.8% in the amount paid to some national chains versus other pharmacies. And PBMs have come under a lot of pressure nationally for taking in huge profits while shrouding their business practices from oversight. The nation's 3 largest PBMs each earn over $15 billion annually, and most states have already passed legislation that are aimed at making PBMs' practices more transparent. So looking at the data here in Pennsylvania, the LBFC report said that in 2017, Pennsylvania taxpayers paid $2.85 billion to PBMs for Medicaid enrollees, and we received that information from DHS, an increase of 100% in 4 years. Then in 2022, Pennsylvania paid $3.7 billion. So what can your department do to rein in this spending, and would you be willing to work with the legislature on transparency measures to ensure good practices by PBMs?
Yeah. So first, let me just put the overall situation of pharmacy spending, separate from the very legitimate issues you just raised, into some context, which is over the last decade or so, we have seen more and more new pharmaceuticals discovered and brought to clinical practice that are really changing how a lot of diseases are managed. And so we are starting to see a shift towards more pharmaceutical costs that is turning into less hospital admissions and other problems. So there has been just a general shift toward pharmacy away from inpatient care as we might traditionally think of it. But to get to your specific questions, we know particularly that this has been an issue that has faced our independent pharmacists. And our independent pharmacists are, in so many cases, just the fabric of our communities. They deliver medications, they provide vaccinations. They were heroes during the COVID-19 pandemic in all sorts of ways. And DHS has heard in particular from them that these pricing issues are really affecting them. So let me run through what we've done to date, and then of course we would be happy to continue to work with you. And this is, some of this is as a result of the LBFC work that has been done already. So it's important to understand that DHS contracts with managed care organizations, okay? And we've talked about they're fully at risk, fully capitated. And the managed care organizations may choose to contract with a pharmacy benefits manager. They're not required to, but they all do, but it's certainly not a requirement on their part. We are able to see those contracts between the MCOs and the pharmacy benefit managers. We're able to review those. At the next stage, the pharmacy benefit manager establishes a pharmacy provider network that meets all the network adequacy requirements. I do want to point out that they are required to take any willing pharmacy into the network. So we do, pharmacies can all participate if they wish. We do not have the ability as DHS to review the contract between the pharmacy benefit manager and the individual pharmacies that they contract with. So what we have worked to do is to require that the PBMs are paying the independent pharmacies what the cost of it is for them to acquire the medication in question and a dispensing fee on top of that. And we've been able to put some measures in place that does enforce that. And we are continuing to monitor that and ensure that is definitely happening. We've seen some payment shifting in the MCOs and a couple of them as a result of that. And we have received many fewer complaints from our independent pharmacies since that was put into place. So that's essentially where we are today. And of course, if we can continue to slow the growth in pharmaceutical costs, we'd be happy to work with you to pursue other strategies.
I appreciate that, and I find it really intriguing that you're saying our pharmacy costs through PBMs are increasing, but our medical care costs are decreasing. And if you could point to where we could find that information in the budget, because overall, we have seen continued exponential growth in the Department of Human Services budget, and looking overall at the numbers, over 5% increase in your spending, I'm not sure that I was able to discern that as I worked my way through your budget document. So I would appreciate
that. If I could, Senator,
that.
if I could just clarify what I meant by that. I meant that in practice, in medical practice, there is a shift to more prescribing of pharmaceuticals rather than having to maybe hospitalize a patient for treatment of condition. A lot more can be done on an outpatient basis using pharmaceuticals than could be done even 10 or 15 years ago. Now, medical costs have continued to rise, right? So we know that is true, but a piece of that increasing pharmacy budget is because pharmaceuticals are just being used more. That was really the point that I was trying to make.
And you would assume that if you see that, you would also see a commensurate decrease. But we'll continue to dig through the budget.
It is an entitlement program that, particularly as our population ages here in the Commonwealth, we do see more people in Medicaid, particularly in these last few years where we've had continuous enrollment. So I think we'll have a better picture of that in another year or two once we're on the other side of the continuous eligibility.
Well, thank you very much. Thank you, Mr. Chairman.